All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today we have another rock star, and this is a special show for you on Sunday. So we have Dr. Syed Haider with us. He is known for one of the doctors who started prescribing ivermectin for COVID. Then I think he's one of the first physicians or very early physicians who started using fluvoxamine in addition to ivermectin and with great success. So let me just quickly introduce Dr. Haider, and then we would start talking with him. So thank you very much. You are a lot of people here already. So Dr. Haider was a National Merit Scholar and attended the University of Florida on a full academic scholarship for 2 years, studying computers and electrical engineering before enrolling at Shifa College of Medicine, where he completed a 5-year medical degree with honors in biochemistry. He completed his residency in internal medicine at York Methodist Hospital in Brooklyn, and afterwards worked for 10 years as a hospitalist before transitioning into general telemedicine in early 2020. And he became focused on COVID-19 telehealth since December of last year. He was one of the first physicians to see success adding fluvoxamine to the ivermectin protocol. I also want to give a shout out to the Redditor Stereo Match, because it was Stereo Match who reached out and said, hey, we want to talk with Dr. Haider. So here we are. Now, Dr. Haider and I have been talking off and on via the phone as well. He is listed on FLCCC's site as well. So here we have a rock star with us. Dr. Haider, welcome.
Thank you. It's really great to be here with you.
So tell us a little bit about your work, and then we'll ask about the protocol that you're using for COVID-19.
Sure. So I started off with ivermectin in late December, or early December, actually, after Dr. Corey's video went viral in front of the Senate. So a lot of people started searching for ivermectin. And initially, I was seeing mostly people who just wanted to prevent COVID-19. And probably January, February, a lot more people started coming in looking for acute care. And then in March, April, I started seeing a lot of long haulers coming in also, and the acute patients rising, becoming a larger part of the practice. And so I think the biggest takeaway I want to give people is that basically what Steve Kirsch has been talking about in terms of my practice experience was that, personally speaking, when I was using ivermectin, and this is one patient's experience, so take it with a grain of salt, but this is what I saw, that I was in the first 20 or so people I had just using the ivermectin protocol. And I think at the time I was also giving some people low-dose steroids, Dr. Mobeen's protocol, in the second week towards the end of that batch of patients. And some people were getting some colchicine. But the main drug that I thought was doing the work was the ivermectin. So in that first batch of about 20 people, I had 2 hospitalizations and 1 near hospitalization. I mean, the patient should have been in the hospital for hypoxia and refused. So he requested me to arrange oxygen at home, which I did. So that was with ivermectin. And, looking back on it, it was a bit unexpected. I mean, you expect the patients to do better. And it was a very small, sample, and, certainly just a lot of confounders and bias. I mean, some of them might have just happened to be very sick. It's just one doctor's experience. But after that, I've treated probably close to 300 people afterwards, after adding fluvoxamine. And with fluvoxamine added to ivermectin, immediately there was a difference. And so when you're in the thick of things, treating patients, you're not always aware of what's happening unless you're really looking for the data. And it didn't really occur to me how much of a difference there was until Steve Kirsch asked me, what have you seen after adding fluvoxamine? And when I thought back on it, I realized that there had been these, 10% hospitalization rate, quite shocking, before fluvoxamine, and afterwards it went down to 0 for the first 200 patients. And also the other thing that I saw was no long haul, patients coming back complaining at day 14 in the 3rd week that they still had symptoms. So we didn't see that happening either. If you started fluvoxamine ivermectin before day 7, so day 6 or earlier, I didn't see any people having long haul or hospitalizations. And then finally, somewhere in the third 100, patients on fluvoxamine ivermectin, one patient ended up in the hospital, but he had basically just started the protocol hours before and then went to the hospital. So I would say that doesn't really count as a fluvoxamine failure. But he was rapidly getting worse, and he had some hypoxia, so he was in the hospital for a few hours. And also, he wasn't able to tolerate fluvoxamine. So, with ivermectin, my experience has been that almost everyone can take acute treatment, and the preventative treatment with ivermectin. It's very rare for somebody to have any issues with ivermectin, and it interacts with, the only common drug is warfarin that we see in clinical practice in the US. So nearly everyone can be on it. And, in my experience with preventative treatment of ivermectin, probably at least 1,500 or more patients so far have started on that. And out of that, I can, probably on the fingers of one hand, count the people who decided to stop. One person had a rash on the face. One person had a rash on the palms and feet. And all of these are self-limited, problems. So they went away after they stopped the medication. One person, elderly lady, she was in her 90s, and really persistent, get me the ivermectin. We had to teach her how to use the computer to even get her, on the protocol. But once she started, she felt dizzy, and she felt too dizzy. And somebody who's old and frail, you don't want them to fall. And she understood that. She didn't want to continue taking it. So there was the, pretty, concerning dizziness for her and for us as well. And that's all I can think of off the top of my head, 3-4 people who weren't able to do the preventative protocol. I do want to just mention that I have had a lot of experience with higher dose ivermectin daily, before the FLCCC recommended in some patients to go up to 0.4 mg per kg. So we were at that dose already for a lot of long haul patients, and still most people tolerate it great with no side effects, but the side effects incidence goes up significantly at that, at the double the dose. So you're talking about somewhere less than 10% still, maybe 5%, but people do have side effects. People get, the blurry vision that's been mentioned in some of the studies. That's a pretty common one. And initially I was, kind of worried, and pretty worried, because you look at the prescribing information, you see that ivermectin can cause all kinds of inflammation in different portions of the eyes. So I had most of them go and get eye exams, whoever agreed to, and the eye doctors actually didn't see any problems. So it was also a benign side effect that wore off, and it was dose related, so one long haul patient, lowered his dose a bit, and the side effect got better, lowered it a little bit more, side effects gone. So people were able to titrate it like that. The other thing I've seen is, when you're treating just one illness, you get to know it pretty well in terms of the side effects and the effects. So with fluvoxamine, the side effects are certainly more than with ivermectin, and that's one of the reasons that I like to, if we don't have lab data from IncellDX, I'd like to start off long haulers with Aguirre-Chang's protocol. Start them with ivermectin because it's cheap, it's super safe. Almost everyone responds, and the people that don't, we can go to drugs that have a slightly higher incidence of side effects, less chance of success, but we can try them later. It's still cheap, and then later on, maybe Maraviroc if you need it, because that for most people is very expensive. It's not always covered by insurance, and even when they have insurance, it's not always covered. So anyway, going to fluvoxamine, the fluvoxamine side effects that I've seen in my practice, mostly nausea, and rarely, you'll see something that's listed on the side effects, like one patient had a bad headache, she had bad body aches, but it's mostly stomach upset, like nausea, and sometimes stomach pain. And these side effects, you can often, moderate them. Insomnia is a big one, so not just normal insomnia, but you feel really strange. Some people feel a little spacey. They feel, kind of strange and out of their normal sense of self. They just don't feel normal. So those are concerning side effects for some people, and that's the reason that the patient who was admitted a few hours after starting ivermectin fluvoxamine actually said, "I can't take fluvoxamine. I just feel very, very weird." And so that was, concerning, because it, it has to do with his sense of self and his experience of reality. So, but again, rare. It doesn't happen very often. And so what I'm trying to get at is with fluvoxamine, when you have a side effect, usually you can moderate it with something like we were using Phenergan now, myself and Dr. Antonatos of Text to MD. So we've been in touch, a little bit through email, and he is the other doctor that Steve Kirsch convinced to try fluvoxamine in the beginning. And so we've been trading some ideas. So, Phenergan does have some interactions with some of the other drugs that we're treating with. But it's, a lot of these interactions, when if you're not really familiar with using these, in hospitals and in patients in the clinic, they sound really concerning, and, they will put people off. So you have to explain, like, for example, with QT prolongation, if you have QT prolongation to begin with and you've had some arrhythmias or something, obviously I would probably avoid something that causes QT prolongation, like the, mirtazapine sometimes we use to help with the insomnia from fluvoxamine, and fluvoxamine, mirtazapine, they can both, theoretically prolong the QT interval. But very rarely, like Dr. Mubin said, I worked in hospitals for 10 years. It's very, very rare for QT prolongation, somebody who doesn't already have it, to be an issue. So frequently, in the hospitals and in the clinic, on my computer, when I'm prescribing, you check the drug interactions, you get these, in the hospital, you get these pop-ups from the EMR, warning. And, as you're going through residency, you pay a lot of attention in the beginning to all these warnings that pop up with drug interactions. And later on, you realize that it just doesn't make much difference in clinical practice. These warnings are like case reports. A handful of patients, in 30 years had this. They found that when they took these two drugs together, they developed a problem. It's really something that individual physicians don't see, and the individual patients are not likely to experience. So QT prolongation, and this is similar to, this just reminds me of this hysteria over hydroxychloroquine in the beginning, right? With all the supposed, dangerous side effects of that drug. That's just people who are scaremongering, and I have to say shame on the doctors who, participated in that in the media, because it's really a safe drug. It's not quite as safe as ivermectin, but still, the things that they were talking about, arrhythmias and things like that, it's not something that you see, and some of the side effects they were warning about were things you would see after years, instead of days, during acute treatment.
Totally makes sense. And I also want to give a shout out to Denise TG. She's one of the cool beans, and I think she's your patient as well. She was talking about, she connecting with you yesterday as well and talking about this one.
Yeah.
So Denise, thank you very much for the reference as well.
Hi,
So yes, so she's here actually. She was one of the early ones this morning. Let me actually see if I can find her messages. She has her messages here. I'm going to go blind now because I'm in the middle of the discussion as well. So a quick thing on my practice side. So I had started with, so it looks like we lost Dr. Haider. So here he is.
Sorry.
He's back. Sorry, no worries. So here is Denise. So Denise has been talking about you for a long time. So she's your fan as well. So my practice, what I saw was, in the beginning, I started with hydroxychloroquine. And so far in my patients, I think about 500 or 600 so far, none of them have become long hauler. 2 of them became long hauler, but were healed or cured, or it went away. And then thank God, none of them have died. So in the beginning, I used to treat with hydroxy and zinc. And then I transitioned toward ivermectin in April timeframe. When the Cali study came out in Australia, that is when I started using ivermectin. And I used to combine ivermectin with hydroxy. And then something happened. One family, they all developed, except mother and father, all children who were taking hydroxy, and adult children, they all developed arrhythmias. I have no idea why, but one family, they all would call me and they say, my heart rate is 58, my blood pressure is going down, and I would get worried because I do telemedicine as well. and I would not be there to see what is exactly going on. And I would say, okay, get ready to go to emergency. And so that was a stressful time for me, because that whole family, 3 children, and then they were okay. So since then, I then started shifting more towards ivermectin. And since I've been using ivermectin, I have never had anyone report any issues. Maybe at some point GIT disturbance, or sometimes some dizziness, but nothing else. So it is very interesting to hear your experience. Dr. Haider, if you give me a second, people have been commenting that how do we reach out to the doctors? How do we get ivermectin? And I think that is an important outcome for today's discussion. So if you're okay, I'm going to quickly share how to reach you. So folks, this is FLCCC's site. So if you go to flccc.net, not .com, they would redirect you to covid19criticalcare.com. Here under this red button, it says how to get ivermectin. So I'm going to make it big. Under this donate to support our mission, how to get ivermectin, if you click there, you would see the list of doctors, and in here you would see so Dr. Syed Haider is here as well. So website is drsyedhaider.com, phone number is this, and there are more doctors too. And I have been in contact with Dr. Syed Haider, he is here, and also with Text to MD, Dr. Antinatos. And by the way, Dr. Antinatos will be with us on 10th of this month. So I just wanted to make sure that folks are aware. And finally, if you are in the US, and if you're going to get ivermectin without insurance, please use GoodRx. You can have on CVS, for example, ivermectin for $226. And then after using GoodRx, it would come down to $20 or $26. So just make sure that you use that. Okay, so back to Dr. Haider.
So I just wanted to mention a couple of things. I've been telling people about GoodRx since the beginning, and I've noticed, one issue with GoodRx is that a lot of elderly patients especially don't realize that they can change the quantity. It's automatically set to 20. You have to click that and you can change it to any quantity and create a custom prescription for yourself, or custom coupon for yourself. And just one other point, I'm actually in 41 states now. I haven't updated the website because we've been so overwhelmed with patients. But if you go to my website and click the About button, you'll see the list of 41 states that I'm in.
So let me very quickly actually go to your website as well. I think the most important takeaway after your protocol is to be able to reach you, because that is the most common thing that folks ask me. So cool beans, I'm going to go to drsyedhaider.com. So here we are. And here, Dr. Haider, what should people do once they're here?
So once they're there, these people are coming for ivermectin and, treatment for COVID. So the COVID-19 button at the top right is the one that takes you to the sign-up form for any COVID-19 related issues. So it's a bit of a more specific sign-up form. So at this point, it just asks you some questions, and it's basically like filling out new patient paperwork.
Got it. So once again, drsyedhaider.com. I'm going to actually put this link here in the chat. So if anybody is interested, please copy this link. I would tweet this link out afterwards as well. Dr. Haider, there was one more question from Cool Beans, and that was, do you have social media presence? Can they tweet at you? Or can they... do you have presence on social media? I
don't at this point, and it was a conscious decision, years ago that, I never really got onto Facebook or Twitter, and I'm considering it now, more of a business presence than a personal presence, but I haven't pulled the trigger yet.
Excellent. So I think as soon as you have your business presence, we're going to flood in and become your fans over there. So with this now, so I hope that by now, there is a protocol that Dr. Haider has used, and with lots of success. I wanted to ask you this question though. So I'm assuming that your practice went something like practicing without knowing what to do yet. So hydroxy was not known, zinc was not known, ivermectin was not known. So practicing with symptomatic illness maybe, then transitioning towards hydroxy, if at all, and then transitioning towards iver, and then transitioning towards ivermectin plus fluvoxamine. Did you have this kind of a transition as well, or?
So in the beginning, I'm talking about last January, February, I was still working in a hospital, and we saw a few. This was what was it called? One of those hospitals. It's an LTAC kind of situation where long-term acute care, and you get patients who have been in the hospital, and then they need continuing hospital care, but they've gone beyond 30 days and they need long-term care. So they go to another hospital that's it's a kind of a feeder hospital. So it takes patients from the acute care hospitals. And back in the beginning of the pandemic, nursing homes, those kind of hospitals, they weren't accepting people with COVID-19. Those people had to stay in the hospital. And this was kind of a different thing. They didn't want to take anyone who had COVID-19. So we didn't see a lot of patients in the beginning. Later on, we started getting a couple of patients. So I didn't really have a lot of hospital experience with COVID-19. Maybe 1 or 2 patients, and they had already improved. They were at like day 40, day 50 after the acute infection. So my experience back then was actually catching COVID, so somebody there gave me COVID. And, I was sick, it felt like a bad flu for the first couple of days. And then, the bizarre loss of taste and smell I had never experienced in my life happened. And then, some trouble with sleeping, and it kind of lingered on for weeks. And then I felt, I thought I was over it. And I didn't realize that I had transitioned into long COVID. I was having trouble sleeping. I would wake up at like 4 a.m. I would, and so to answer your question, I didn't know anything about treating COVID-19 back then. Literally zero. It was nothing at all. I don't think even heard of hydroxychloroquine at that point. I must have heard of hydroxychloroquine, when President Trump talked about it. But I didn't think of trying it, for myself. I'm not really a big medicine person, so I don't often use medicine myself, rarely. So the first thought was like maybe treat it with herbs, but in the acute infection, it just didn't seem like a big deal. I thought I would get over it. So I transitioned into having long COVID, and like I said, I didn't realize it was long COVID. I thought I had just developed insomnia. I thought my heart was racing sometimes from anxiety, maybe. So I was having these kind of symptoms, and they lingered on for months, pretty long time, and then gradually kind of went away. And then people started coming, like I said, with long COVID in maybe January, February. The first people started trickling in, and then the light bulb went off. I was like, oh, that was long COVID that I was suffering from. And so, I didn't treat myself. I was patient 0 or patient 1, for myself, and I didn't treat myself. Then I was working for basically Teladoc. They're a very large telemedicine company, general telemedicine company, and I was seeing patients coming in with COVID sometimes. Not a lot, because this was urgent care online telemedicine. Most of them were going to, on the ground, trying to get treatment in person. But some people would come, and at that point, I don't remember exactly when, but far before December, months before December, I had, ivermectin had come onto my radar. I had heard about the FLCCC. I'd heard about, their protocol. I didn't have much experience with it, but I started telling people that, hey, this looks like it can work for prevention, for treatment, and usually, I would get this blank stare from people, trying to tell them that there's a medicine that can work, and it's called ivermectin. And it's like, you've never heard this word before. It's like a very strange, weird, alien sounding word. And so 99% of people would just be like looking at you as if like, this can't be a thing, what are you talking about? Where did you get that from? Because they've never met me before, this is just urgent care online, and you've just met them for the first time. So you don't have their trust. And so they have never heard of this anywhere else. They think you can see the wheels turning in their head that if this was a real thing, if it really worked, I would have heard it on CNN, or NBC or Fox or somewhere, right? Or on social media, somebody on Facebook would have talked about it or something, So that wasn't happening at that time, and the word hadn't gotten out. So about 1% of the people I saw were willing to try ivermectin, and kudos to Teladoc. They weren't, interfering with doctors' practice the way it seems a lot of corporations are interfering. I get a lot of patients who come to me with this bizarre experience that they've never had in their life. of the doctor told me to call you. They said, I can't treat you, but here's Dr. Heather's phone number, give him a call. Just shocking that something like that would be happening in America. I grew up here, and it's something that we never imagined or thought could happen.
And so, sorry, just a quick interjection. And I actually feel this shocking as well, that people in America are having to go find horse products or other products and in desperation trying to use that, because the doctors and the leading organizations are rejecting and actively saying don't use it, undermining it. It is a very sad thing. I cannot even, when the historians would write it down, I cannot even imagine how embarrassing this will be.
I agree. So to continue the thread with the experience of treating, so that was my first experience. A very small percentage of people accepted ivermectin and went ahead and treated it. I didn't have any follow-up at that point with Teladoc, so this was a drawback, to being on that platform. And then Dr. Corey's testimony went viral, and more people started searching for it on a different, my patient portal that I used. They were coming through the portal as basically patients who didn't have a doctor assigned and just requesting ivermectin. So I started treating those people mostly with prevention regimens and a few acute patients, and then I just decided to set up my own practice, and I realized that I could put my name up as the doctor who's prescribing ivermectin and actually end up helping a lot more people who had already been convinced. They'd already heard about it from somebody, and then you get a lot of word of mouth and family members telling each other, and it started showing up on social media. So in the beginning, I was basically using ivermectin, and then at some point I spoke with Dr. Daryl DeMello in India, and he told me about his experience with thousands, tens of thousands of patients using colchicine. That was his favorite. So I put colchicine in there with ivermectin. In my experience, again, my personal experience, and also maybe it's cultural, maybe it's, I don't know what, but maybe it's just, the types of patients that were drawn to me. My own experience with it was that it was pretty limited, especially for long COVID. I didn't see a lot of success with it. There was a lot of GI side effects that would just turn people off on it. And it didn't seem to make much difference with acute infection, although maybe it does. I mean, it should, because of its mechanism of action, interleukin 1 and 6 suppression. But it didn't seem to be a big game changer for me and my own patients that I saw. And then at some point, also I talked to Dr. Mubin on the phone, and he mentioned his dexamethasone. So I started putting people on that in the second week, or in the beginning at some point. And I think those were the core, drugs: ivermectin, colchicine, dexamethasone, and then I saw the budesonide data. I threw budesonide in there, and I was just piling things on in the beginning. I was like, this could work, that could work, that could work. And the acute infection, I think that is a good approach. You're limited somewhat by interaction, drug interactions if they occur, and something that people don't realize is they'll come to me and ask, does ivermectin interact with ashwagandha or turmeric or something that I'm taking, right? And I don't know. I mean, I can try to figure it out, but it's not something that we can very easily figure out. And the more drugs you throw on, like when you're asked like 4 or 5 drugs, you need like a supercomputer to figure out how they might be interacting, how theoretically possible that they could interact. So you get to the point where you can't predict, and then you start running into problems with side effects that are unexpected, and like a lot of the side effects could be also COVID effects, right? Like diarrhea, stomach pain, headaches, nausea. A lot of these could be COVID, or they could be side effects, right? So you become a little confused. Is this working? Is it not working? Should we push forward and try to treat the side effects and keep the drug, and is it benefiting?
And what I have been doing is, on this one, what I have been doing is that I ask patients, I'm sure that you ask them as well, and I actually ask them to stop those things. Just not that I'm against them. Actually, if somebody listens to my videos, they know I'm very much pro herbs and other things. But I ask them to stop just so that I don't have to deal with those side effects which I cannot understand. And then I start this medicine, and then I can slowly work back with their medications. Sorry, so please.
Yeah, that's great. I'm glad you told me. I mean, one of the reasons actually I wanted to come on here with you is basically to learn from your experience. I feel like I should interview you instead of you interviewing me. You're the teacher. I'm just a humble student. I don't know that much, and I don't consider myself a teacher. So thank you for sharing your experience, and please share more of it.
Thank you very much. I actually think that your protocol of ivermectin with fluvoxamine is it is something that should be more publicly used. Your experience has been great as well with this as well. So I am loving it. So thank you very much for being here. Now, if you are ready, there are some questions as well. So we can do a quick hit with those questions.
Okay, sure.
So first of all, I'm going to look at, so folks on the live side, please, if you have a question, please put something, question marks or the letter QQQ, so I can see that out of all the comments that are going on. I'm going to start with Terry. Terry is saying, Dr. Haider, do you prescribe ivermectin for prophylaxis as well?
Yeah, this has probably, been 90% of my practice in the last 4 months is preventative treatment. And, we can talk about it a little bit. The FLCCC, on their site, when you go there, and always it's been like this, is we recommend ivermectin for prophylaxis for high-risk patients. So, this is something when you have a group and you have like guidelines, of any kind of organization, you have to err on the side of caution, and you don't want to say, okay, everyone in the population should be on ivermectin. Although I believe, and I think a lot of people have actually mentioned that if everyone was on ivermectin, the pandemic would probably be over in a few weeks. So, we don't know like who is high risk, right? Like, so we have a list of, age, and we have diabetes and high blood pressure and heart disease and lung disease. And, et cetera. We have a big list from the CDC of what constitutes a high risk medical problem or patient. But on the other hand, you have doctors who are in ICUs, even if they're extremely healthy, they're obviously high risk because just the pressure of, not the pressure like job pressure, but, the amount of COVID that they're experiencing, that they're exposed to is so much that they're very likely to catch it if they don't take something. And then you have people in overcrowded conditions. You have people, one of my patients was in a high-rise building with a lot of people with COVID and her neighbors. If you're living with a lot of people, if you're, it depends on which country you're in. It depends on your risky behaviors. Do you wear masks and distance and avoid people and don't go out? Or are you out everywhere all the time? Is there a lot of COVID in your community? Are there high risk variants? So all these things kind of roll together into deciding whether you're high risk. And this is my perspective. And one final thing that, probably doesn't get a lot of play is that, there's such a large percentage of people get long COVID, and we don't really know that much about long COVID. Is it going to last for months or years? Is it going to, is it going to cause permanent damage in some people? So, when people come to me, I don't make them convince me that they're high risk, because ivermectin is such a safe drug. And, I'm giving them a 3-month supply, ask them to come back, ask them all these questions, make sure they're not having a problem with it. And we can consider doing lab tests if we want. It's you look at the risk benefit ratio in medicine, right? What's the possibility of benefit and what's the risk that you're going to take for that benefit? And it's just like overwhelmingly in favor of using ivermectin if you're worried about COVID for any reason.
Absolutely correct. Absolutely correct. And so the Redditors who are watching, I know that you have your questions. You are the one who started this whole discussion as well. So I'm going to go to those questions in a second. Kevin Brazda, he's a cool bean. He's saying, Dr. Haider, your patient here, you have said ivermectin is 95% effective at prevention, yet Dr. Bean has said it is 74% effective. Have you adjusted efficacy range with any new data? So let me first explain my part here. So my discussion of 74% comes from the studies that were done in Egypt and India. It is possible that there are more studies that Dr. Haider may have seen or his own experience as well. So Dr. Haider.
So yeah, Kevin, hi. He's asked me the same question, through my patient portal, and I told him probably similar to what I'm going to tell him right now. So certainly in my practice, what I tell people is that, doc, I can speak for my practice, right? And I can point to some studies where it was 100% effective, other studies where it was, much less effective. And so each of these, studies, and each of these situations are different. There's different groups of patients, right? And they're in different countries, they're in different situations, there are different types of people. There's people who are doctors being studied in some places, there's a general population, they have different living conditions, they have different socioeconomic statuses. So it really, whether something is effective is going to depend on all these other variables. It's not just the drug itself. So, you can, if you're sitting in your house, you're not going anywhere, you don't need to take ivermectin. You're not going to get COVID-19, right? If you're sitting in your house and you're very rarely going out, and you're on ivermectin every other week, in my experience, out of probably at this point 1,700 prescriptions of preventative ivermectin, 99.9, like just a handful of them, I told them, okay, take it weekly. If they wanted to take it weekly, or I was like, okay, you're an ICU nurse, take it weekly. The vast majority, I gave it to them every 2 weeks. None of them came back with COVID. And so in my practice, I'm looking at my patient population. I'm saying, okay, these people are being careful, for the most part, and they're not living in crowded conditions. They're not, in a place where there's a real massive outbreak of COVID. So I will tell people now that, I sent a message, yesterday probably about the, just my thoughts on the FLCCC update. Should you take it weekly? And, if you decide to take it every 2 weeks because you're, thinking, we don't really know the long-term effects on being on ivermectin for months, years, every 2 weeks, I'm a little worried about that. Some people approach it that way. They're a little worried about that aspect. And so they say, okay, monthly, definitely not super effective in the studies. Weekly, very effective. Let's split the difference. Every 2 weeks seems to be good. Get the best of both worlds. If you're in that, group who want to take it every 2 weeks or even every month, and you end up flying, then take it weekly, right? Or you end up being exposed to somebody, take an extra dose, right? So, so to wrap up and just, answer the question, I honestly, like I told Dr. Bean before the show started, I have not had time in the last 4 months to really dive into all these studies. So I'm not the person to ask about, the science aspect of it. I can tell you my experience and just my perspective, which is that it's an extremely effective drug if you continue to be cautious.
And I think that you're spot on, because the study that I refer is actually a study on healthcare workers. Mm-hmm. So they were on daily basis exposed to COVID, and then they gave them dose 1 and dose 3 days later, another dose 1, and that's it for the whole month. So that is a very different dosing. Plus, that is a very different environment.
Right.
Yes.
I did mention this to Kevin also in our discussion that, the dosing protocols are all over the place, like all kinds of different dosing protocols. So it's, you have to take that into account when you're looking at this.
In my experience with the prophylaxis, my protocol from the very beginning, March, April, has been weekly prophylaxis. I am yet not, and the reason is the science behind this, that I'm still not very much clear for how does the ivermectin stay in the tissues after first dose and third dose for the whole month. These studies show that it does that, but because I'm not very much clear on it, the half-life is 18 hours. So I feel that 1 week is, I would even have made it more frequent. So 1 week is a decent number. So I'm going to go to the Reddit friend. So here, this is so you should have your Twitter. I'm saying this with humility, not demanding it. So Stereo Match from Twitter, from Reddit, has put together this Twitter subreddit where they have the questions for you. And Stereo Match, thank you very much for actually going to various areas on Reddit, curating the questions. He actually got removed. The post got removed in one of the places as well. Most of these questions here, I felt that there were a lot, but most of these questions here are about dose, interactions, using it with food or not. So I'm going to go quickly over them, and please expand wherever you feel that you want to discuss more. So first, famotidine. Fluvoxamine seems fine with ivermectin, NAC, etc. Question is, famotidine plus fluvoxamine, is there any issues? And I'm going to open up the drug interaction for you here that I have, fluvoxamine and famotidine. They say there is no drug interaction. Anything from your experience?
So I haven't actually used famotidine, and I'd be interested in hearing people's experiences with it. But I just, I know that, obviously some patients actually come to me and say, what about this? What about that? And I got to the point where I wanted to, pare it down and simplify it to something that works. And it seems like you don't have to keep adding things if you have something that works really great. So there are, dozens of drugs that you could add to the protocol. At what point do you stop? What is it bringing an additional benefit? And what could it be detracting? It could possibly be detracting. If you add something, you have to always consider side effects, interactions. So if I have people on, for a while, actually, I was adding amantadine to see if we could, make it even more effective. And then, you get to the point where somebody has a side effect, like, which one is it, right? Which one do I need to remove, or which one is not working for them? So at some point you have to say that in order to keep it really simple, in order to know which is possibly causing a side effect, how to tell the patient, okay, maybe stop this one and, max out the dose on ivermectin, for example, you have to have a simplified protocol for most people. And then these secondary drugs, I would consider them if for some reason somebody can't take the main protocol drugs. But I haven't gotten to the point where I've actually even looked at the famotidine data. So Dr. Mubin, do you know something about?
Yes. So famotidine has been in studies shown very good results and reduces the symptoms and the viral load within 24 hours. I think one of the reasons could be, and I had prepared in your honor, I had prepared this long haul. Maybe you and I should do one more talk about the long haul separately and talk about what are the possible things here. I had shared this with the cool beans as well. In the long haul state as well, it is actually possible that sometimes, excuse me, sometimes antihistamines are actually useful. And so famotidine may be playing a role there. My own practice, I have not used famotidine a lot. So there are
actually one thing I haven't mentioned before is that just recently, one approach was to try to add amantadine to get rid of the, to increase the efficacy even more for the very small percentage of people who on ivermectin and fluvoxamine still worsen. But the other approach that we recently added is actually cyproheptadine, which is mentioned as one of the supplemental drugs by the FLCCC. And I think, that has some antihistamine effects, that has, anti-serotonin effects. So I think that is much, stronger and much, for people who are progressing, their lungs are getting much worse, they're developing hypoxia. That is really, the salvage therapy that you would want to use.
That's a beautiful point. I'm going to have Dr. Fareed Jalali, I think, tomorrow or day after. And he is a cyproheptadine guy as well. So thank you for bringing that up. Fluvoxamine. So any insights in different dosing strategies for fluvoxamine? 50 milligram twice per day for 14 days, Steve Kirsch. But has there been occasions for pulse dosing or low dosing or a different dosing?
So this is a great question because some patients are just, for whatever reason, genetic or physiologic, whatever, there's something going on in them and they're much more sensitive to a drug. And so in that case, if somebody says, okay, this is like overwhelming the side effects or whatever, I just feel like this is too much. I will go down if they're willing to, go down to a lower dose. Maybe their body metabolizes it differently than most people's. So I've had experience with this, especially for long haul treatment, where we'll tell people, just use whatever dose works for you. If I have actually with long haul seen a couple of patients, who just felt like ivermectin was like super, super strong, especially the people who have like Lyme or some kind of chronic Lyme co-infection, or, they feel like extremely sensitive to any medicine. They get like a Herxheimer reaction when they take something. They feel like they're having some kind of die-off or just some horrible reaction. So some people, they'll literally take like half a tablet, like 1.5 milligrams of ivermectin, and tell me that it was like too much, it was too strong. So for some people, they can tolerate, you would expect them to be able to take, for example, one of my patients, I'd expect her to be able to take 12 milligrams. Her dose, 0.2 milligram per kilogram dose, is 12 milligrams. And she says that at 12 milligrams, she feels like this chest depression. She feels, and she has long haul. And at 9 milligrams, she feels great. Her symptoms are gone. She doesn't feel bad. And at 6 milligrams, still some symptoms. So I said, 9 milligrams works for you? Wonderful. Use 9 milligrams.
Absolutely.
So it's personalized. You have to personalize everything.
Got
So
it.
there's definitely a way to do that.
Got it. Got it. Thank you. Thank you. Caroline Arendt says, when a patient is already taking a different SSRI, would you lower the dose and give fluvoxamine along with it?
Yeah, so I've actually done this. The official recommendation is not to do that. If you're on an SSRI, just stop. I've done it. I haven't done that for SSRIs. What I did with SSRIs was told people to just stop their SSRI and go on fluvoxamine. And I think that's a pretty easy switch to make when they're both doing, the serotonin reuptake inhibition, and fluvoxamine is just doing the sigma-1 activation better. So I have not had problems with that, and I wouldn't expect to. Why would you? It's basically taking the place of your drug and doing something else that you want for COVID-19, and then you can go right back to your SSRI, right? So if you're taking a daily SSRI, 24 hours after your last dose, I would tell them to start the fluvoxamine, and then 12 hours after the last fluvoxamine dose, go back on their SSRI. No problem so far, but not a lot of it. I mean, just a handful of people who I did that with. Other people, like on Wellbutrin, for example, I think it's a norepinephrine serotonin reuptake inhibitor or something like that. So it has a mixed mechanism of action. So for some of those drugs that aren't pure SSRIs, I have told them to either lower it or just try it and see, and very carefully see if they have any side effects. They're not absolute contraindications. I mean, they are mixed sometimes. So again, no problems with that either so far.
Got it. Got it. Thank you very much. And I want to quickly remind the Cool Beans, the listeners here, that so this is based on the questions I've been getting. Some of the psychiatrists, psychologists have been saying that, why are you giving antidepressant? Do you feel that the people are depressed and that's why you're trying to treat them as depressed people? That's not the case. There are actually studies that show that fluvoxamine molecule has benefit. And we realize that for depression, this may be given for a couple of weeks and then the effects start coming in. But this molecule for COVID cases, especially for the neurological symptoms, starts acting right away. So if you wanted to see it, here is an important, I've done this video. Sigma-1 agonism is actually started from the day one. And that is an anti-inflammatory behavior. It suppresses the cytokine production. This is a very similar thing that on the systemic area, not neurological side, ivermectin is blocking or suppressing nuclear factor kappa B. And in the neurological side, the fluvoxamine is helping with the sigma-1 agonism. So they both can actually partner together and work holistically on the body. So just to update it, that the mechanism is not antidepressant that is working here. It is that is a side effect, meaning in a good way that if somebody needs it, that is there too, but it has an anti-inflammatory
So
outcome.
this just reminded me that I should mention that, if we were going to go down on the dosing of fluvoxamine, the reason it's twice a day, for depression, it's once a day, but the reason it's twice a day for COVID is because of its, the serum half-life. We think that, it's dropping and we want to boost it back up again. So if you were going to go down on the dose, you would still want to keep it twice a day or more even, so.
Got it. So frequency has to be twice a day or more, but the dose can be low. Got it. So fluvoxamine for long haulers, Dr. Bean and Steve Kirsch mentioned for use where ivermectin cannot go, brain and neural areas and immunoprotected areas which may have low level viral persistence. I just talked about it as well. I think there is a fluvoxamine.
So I think this brings up a good point that people who come in with brain symptoms think that they have a brain problem, right? So it's not always the case. The problem can be outside the brain, but being manifested in the brain. So, we've known this forever that people with metabolic disturbances or, liver failure or something, they're going to have brain dysfunction. And when you're testing somebody in the hospital or in the ICU for brain function, the neurologist will come in and be like, yeah, first fix their kidneys and fix their liver and fix this and fix that and fix their sodium level. And then, I'll assess whether they have, brain damage or whatever, or whether they're going to be able to come back from this, whether they're in a coma or not, right? So it's the same thing goes here. A lot of long haulers come in with brain symptoms, and I tell them that you have inflammation in your body. Maybe it's in your lungs, maybe it's in your liver, wherever it is, you have inflammation. And the inflammatory, cytokines can go through the blood-brain barrier. It doesn't mean you have virus in your brain necessarily. Possibly, that's a possibility, but you see a lot of people get better without a drug that passes through the blood-brain barrier. A lot of people get better from brain symptoms taking ivermectin. Why? Because the problem's not in the brain. The problem's outside, but it's leaking into the brain. And so it's not viral persistence in the brain for most people. It's inflammation in the body causing brain symptoms.
And I want to add to this point. This is such a beautiful point, and I hope that this is understood more and more. It is not the virus going into the brain. So many people who send me studies that the virus is found in the brain, these are on autopsies, and I have done this discussion many times, that a person who actually ended up dying with this disease, their blood vascular system is all messed up. They are in a cytokine storm. They are in an acute respiratory distress syndrome. They are in a septic shock. For their tissues to have virus in them is not unbelievable. The virus would have crossed lots of barriers because those barriers would have torn down. In a healthy person, an outpatient patient, it's not necessary that either the spike protein or the virus has crossed the blood-brain barrier. So very good point.
Great. Thank you for bringing that up.
Fluvoxamine for serious cases, anecdotal cases, and ICU, though some of this info is in the Fluvoxamine JAMA, but any interesting stories? So have you seen fluvoxamine with the serious cases?
Yeah, I mean, unfortunately, I get a lot of people who are extremely sick and they don't want to go to the hospital. And it works, the protocol works, regardless of how sick you are. It might take a little longer if you come in later. So this is something, that I give, I want to probably make a couple of points here. First of all, this just reminds me of the fact that it's really unfortunate that the only way 99.99% of people can get a drug that works in the hospital for COVID-19 is to persistently complain of depression. I first saw this in one of Steve Kirsch's papers. He's recommending people, in one of his blog posts, if you have COVID-19 in a hospital, just say I have depression and get on any SSRI, and then after that, it's an easy, jump from any SSRI to fluvoxamine specifically, or even fluoxetine, which probably has, as good effects as fluvoxamine. So this is, this unfortunately, I do get a couple of, people calling me, family members distraught that my husband or my mother is in the ICU or, in the hospital, unventilated and everything. Can you help? And I've tried even once for my own patient. They were already my patient before, and they ended up in the hospital. And I called and spent 30 minutes on the phone with the doctor, the hospitalist. And this was in the middle of nowhere in South Carolina. I mean, he didn't have a lot of oversight. He could have prescribed it. It wasn't a big jump for him. It wasn't a big deal. But you compare that to people who are in Mass General, or they're in a giant hospital, 1,000 beds, and they're in this, corporate system where, they're being watched like hawks, and if I try to call these people, I mean, they've never heard me, of me before, they don't know who I am. I haven't published papers. So I'm not going to carry any weight with these people. That's what I try to tell the people on the phone. The only thing we've seen succeed is you get, the proper education yourself, and then you advocate really, really strongly for the patient in the hospital, forcefully, extremely strong. And so the only one I've seen who's had a lot of success with hospitalized patients convincing the doctors to use drugs is this critical care nurse in Texas. Her name is Lori Jean. And I mean, I don't know if she wants me to share, but if you're interested, if you have one of these situations, get in touch with me and I can give you, she's basically doing this pro bono. I mean, she's not accepting payment. She's not doing anything, but she's spending time on the phone, calling the family member, educating them enough, giving them pointers how to talk to the doctor, how to convince them to use fluvoxamine or ivermectin. She's big on ivermectin. And so I haven't personally had this experience because I can't convince people to use it in the hospital. It's impossible to call in. And once the patient gets to the hospital, this is another misconception people have. Oh, you're licensed in Texas. My father's in the hospital in Texas. Can you prescribe it for him? No, you can't prescribe it. The only person who can prescribe in a hospital is the patient, are the physicians who are seeing the patient in the hospital. And I think most people probably know this, but a lot of people don't. They call me and expect me to be able to just give them a prescription. They can go to CVS and get the prescription and take it to the hospital and say, hey, the doctor prescribed this, give it to him. It doesn't work like that. And, and I know that a couple of people, they didn't come out and say it, but they basically tried to smuggle these things into the hospital, right? Because they're so convinced it works and the hospital refused. Obviously, I can't tell them to do that. And the reason, obviously there's a safety issue here. I don't know everything that's going on in the hospital. That's the reason I can't prescribe in a hospital. You have to be on the hospital staff. You have to be seeing the patient. You have to have the chart in front of you, all the tests, all the other drugs that they're giving. What are the drug interactions? Fluvoxamine does have serious interactions. Unlike ivermectin, there are frequently a lot of interactions. So wouldn't be something that I could prescribe. So unfortunately, I haven't, just in my experience, it does work for serious cases. And unfortunately, like I said in the beginning, we do get some people who are really sick, who are on oxygen or go on oxygen, as outpatients because they refuse to go to the hospital because they know that they're not going to get what they need.
Got it. Thank you very much for that answer. Kevin Brazda says, Dr. Haider, my friend has long COVID with heart issues, recurrent heart palpitations, recurrent fatigue. Do you think resolution of long COVID can be related to age, sex, health state?
Yeah, certainly it could be. We just don't know enough about it yet. And those symptoms are very common with long COVID. They frequently get better and go away with treatment. What we're seeing a lot of, which is strange, this just reminds me, it brings it up for me, is that I don't get a lot of long COVID in elderly patients who are at higher risk for acute COVID. The vast majority of severe long COVID that comes to me, or even moderate or mild, are people, 20 to 50, 20 to 55, and they're generally very healthy. So they're like the healthiest people are getting long COVID. And, it's frequently triggered by exercise. I tell all the acute patients, don't exercise for 30 days. I think this is what Dr. DeMello told me. He was like, tell everyone not to exercise for 30 days. Don't drink alcohol. Don't, eat junk food. So literally people will come to you and you'll ask them, oh, was it triggered by exercise? Or they'll tell you it was triggered by exercise. One lady, all she did was go for a hike, pushing a stroller up the hill, for 2 hours. And she developed long COVID. And a lot of these patients feel perfectly normal. And then, they do something, like exercise, or they have a birthday cake, and then they get long COVID after that. So maybe they would have gotten it no matter what, but, that's certainly something that seems to be a trigger. And so, COVID does seem to affect, different ethnicities differently. There is some, data to suggest that. It seems to suggest people, affect people, different ages differently, affect people different health levels differently. So it's a very strange disease. And so, yes, I think that the long COVID people, in terms of getting better, and, you might need to tell people who are gym rats, don't go to the gym until you get better. You don't want a setback until you're better. And it's probably very similar to chronic fatigue syndrome, those patients where exercise is actually a net negative for them. It's not a positive anymore. It actually is creating biochemical, damage in the body every time they exercise. So this is also just, it seems like I like to talk too much. I just keep going on, but I want to look, I'd like to learn more about the link between chronic fatigue and long COVID. Are these the same thing? Are they just similar? And could, chronic fatigue be treated with things we're using for long COVID? I think, Dr. Patterson's work with the Incel DX test, I would love for him to do something like that with chronic fatigue and other inflammatory diseases. Can we get more targeted anti-inflammatories for rheumatoid arthritis and Lyme disease and, all these other things?
Got it. And Dr. Haider, I think we should do another session if possible, if you have time. And we should go over the long COVID work and the studies that I've collected so far and the possible reasons. So it seems like long COVID is not just one pathology. It seems like it's a syndrome. And then the pathologies could be MCAS, or it could be macrophage activation syndrome, or it could be some virion of the virus sitting around, or it could even be the virus hit and run, where the cells that are proliferating very fast after the viral attack, those cells have opened up certain genes for cytokines, and now they are stuck in that state and they're just replicating with those genes open, and the virus is gone, but they are just secreting. And so giving steroids or giving ivermectin things can kind of suppress them. I'm going to continue on. We have lots of questions here. So once again, thank you very much from all Cool Beans and from Redditors here and from me that you are here and adding so much value. It is life-saving value. High dose ivermectin seems to work for taste and smell loss. Any similar observations for fluvoxamine?
Yeah, so a couple of people, the taste and smell got better on fluvoxamine. So, some people, most people, a large majority who come with long COVID, they take ivermectin, they get better. most of their symptoms go away, or all of their symptoms go away. And the people in my practice, the people who don't have any improvement with ivermectin, I tell them add fluvoxamine or start fluvoxamine instead and see, because when that works, it's like flipping for me, what I've seen is like flipping a switch. I mean, it's like a light bulb turning on. It's just like very fast and just like symptom to no symptom within a day or two. It's amazing usually. So yeah, fluvoxamine helps with that in some patients. And I think, I think what this brings up is that it really depends on, from Dr. Patterson's point of view, his research, what it depends on is what is the problem. You can have a clinical manifestation that's due to 3 different things, in 3 different people. And even though it's taste or smell loss, it's not the same thing. And that's the problem with trying to figure out which drug will work for long COVID. Any of them could work. It depends on what the inflammation, what's causing the inflammation.
Correct.
Does the drug address that inflammation or not?
Correct. Just a quick anecdote, again, not a study, not data, anecdote, that one of the long haulers, Drbeen, reached out to me, and I suggested that fluvoxamine has been working very well for neurological symptoms, at least. It works very well otherwise too. And he took it and he reported back that, hey, my tinnitus actually increased. So then he withdrew fluvoxamine. Maybe if he kept using it, may have or changed the dose. Anyways, he stopped fluvoxamine and started antihistamines. So leading on the point you're making, there could be multiple pathologies all leading up to inflammation, which has similar symptoms in all cases. So he started antihistamines and he started improving very fast. So just if fluvoxamine somehow exaggerates the symptoms, then maybe antihistamines can be useful too. Question from William. Dr. Haider, I worry that ivermectin users are on the younger side, 30, 40s, 50s, swaying the statistics in age 65 plus. The mortality is higher, 15%-ish. What would you guess your mortality is for 65 plus? Very interesting question.
So there's one patient that I have lost contact with, right? An elderly lady, I think in her 80s. And, I'm worried that she may have passed away in the hospital. She was one of the earlier, one of those 2 patients who were hospitalized in the first 20 on ivermectin alone. So I have to, reach out and find her family and figure out what happened. She may have made it, people, they get better and then they don't call me again. So that's also a possibility. But yeah, there hasn't been so far any confirmed mortality in my patients. So, maybe 350 or, something like that I've treated. And I actually have a lot of elderly patients, that are using telemedicine. They're using the computer for the first time, it seems like, sometimes. So it's not just young patients coming to me. It's mostly elderly patients, mostly over 50. Yeah.
Got it. Thank you very much. That's actually a very important data point. Ivermectin. So thoughts on refresher doses of ivermectin weekly for a month post-recovery, as suggested by Dr. Hector Carvalho. So Dr. Carvalho says 100% of the long COVID patients treated with a weekly dose of ivermectin were symptomless after an average of 36 days treatment.
That's amazing. I'm glad that I didn't know. I haven't seen that comment before. So I agree. When people, I've been using so far like a really aggressive, Aguirre-Chang's protocol where it's like, daily or twice a day or something for, 5 days as the test and see if it works, and then continue after that if it has an improvement. I have seen, one patient who didn't have improvement with Aguirre-Chang's test, version of let's try this out. And, he would have said, stop it. The protocol suggests, okay, don't use it because it didn't show any benefit in the first week. And the patient wanted to continue. And I was like, fine, you're not having any side effects. It's safe. Let's try it. So he all of a sudden had complete resolution at week 3, after taking daily ivermectin. It might have happened after taking weekly ivermectin too, because certainly it's in the tissues. That's what we see from the preventative studies. You see some people with Lyme disease, they're taking preventative dosing weekly or every other week even, and their Lyme disease clears up. So you may not need such high doses. Maybe you just need a weekly dose or every other week dose or even monthly dose, might make a difference. It's just people who come with long haul, they're so desperate usually that they're reaching out to a doctor. Finally online, they find you and they don't want to wait. A lot of them don't want to use the weekly dose or something. So that's one point. After full recovery, A lot of people will say, okay, I'll just do the weekly dose or the every other week dose. And occasionally their long haul will come back, and it means it was never completely gone. And then we'll do another, round. And, some people are seeing that they don't ever have long haul symptoms again after the first, 2-week, push of treatment. Other people, I had one patient, I think he stopped after like 2 doses of ivermectin, all completely cleared up. This is like the first patient probably I used with long haul. It was like amazing. And then, a couple of weeks later, he had like my go-to example is the birthday cake. He had some kind of cake or something, some junk food, and his long haul came back. And then he did a couple more days of ivermectin, and since then he hasn't reached out to me in like 3 months. So I think the main point to stress is that with long haul, we don't know so much about it. And it's like the patient has to be part of the experiment. They have to be willing to try different things and figure out what works best for them. Because for some people, I've seen you take fluvoxamine in the morning, you feel terrible. You take it at night every day and you feel great, right? And your long haul disappears. There's no hard and fast rules with this. And probably with anything in medicine, we shouldn't have hard and fast rules because everyone is so different. Different things will work. The published guidelines are just guidelines, really. This is a starting point, and then we have to create this N=1 experiment with this one patient and see what works best for them.
Absolutely correct. And interestingly, I think one takeaway it keeps amplifying in my head, while a patient is ill with COVID, very early usage of ivermectin, fluvoxamine, then in 6-7 days time frame, usage of steroids, these things have been helping patients not to become long haulers. So I think correct treatment is also very important.
Absolutely. Yeah, this is another great point that, a lot of people come to me and they want that medicine cabinet, 3-4 drugs to keep in the medicine cabinet in case they get COVID. And I warn all of them, that I rarely see people take this on day one. When they have it in their medicine cabinet, they don't take it on day one. So you have to decide for yourself, do I get sick every month or do I get sick hardly ever? If you're one of these people who never gets sick, then at the first sign of symptoms, you have to assume it's COVID. Otherwise, you're way behind. You're already behind at day one because the virus has been replicating for days at that point. So just psychologically, you have to prepare yourself. If you're going to keep it in the medicine cabinet, you're not going to go on preventative treatment. You have to prepare yourself for day one treatment. Don't wait until a lot of people, they get that first symptom and they'll come back to me. These people who have the medicine cabinet prescriptions, they come back to me on day 5, usually, saying that, oh, I got the test. It is COVID. Should I start treating now? I'm like, yes, definitely. You should. Yeah.
It's getting late. Yeah, you're absolutely correct. And this is why I think the best way to manage this is prophylaxis first, as you do, and then early aggressive treatment second if the actual disease occurs. And within that treatment, the ivermectin, fluvoxamine, steroids, they have a very important place as a prophylaxis during the treatment from the long COVID. And then if still the long COVID occurs, then there is a management for that. I'm going to continue here. More questions. So one more question about the fluvoxamine dose. So you have said anywhere from 9 milligram to 12 milligram. Have you used higher doses as well?
So I think they're asking about fluvoxamine, but if we want to know about ivermectin, ivermectin, I'm using 0.2 milligrams per kilogram. So if somebody's 300 pounds, they're going to get a huge dose. I give like 10 pills to some people, 30 milligrams to somebody who's over 300 pounds. So I'm just using weight-based dosing for ivermectin. With fluvoxamine, the dose that has been beneficial, 50 milligrams twice a day is what we use for most people. And it's a great dose because most people don't have side effects. It's very, most people tolerate it well. For long haul, often I'll start people on 50 once a day and tell them do it for a week. If you're not having any benefit, go up to twice a day and see if that helps.
Got it. So here is an interesting one. I'm on 50 milligram per day and have been for 2 weeks. Might be helping with headaches, but also might be increasing demoralization and brain fog. Yeah.
So, at this point, I would lean towards trying something else. If this was my patient, instead of doubling, you could try going to twice a day, but if you're having side effects already at once a day, and you haven't seen benefit in 2 weeks, I wouldn't expect to see benefit by continuing longer with fluvoxamine.
So this is an interesting question, and not just for the fluvoxamine. I would say this for ivermectin and steroids, all this combination. When you have been managing long COVID, do you see people becoming fully cured, or do you feel that you take the medicines off and they bounce back, or there is a mixture?
So there's definitely a mixture. Some people seem to be completely cured, and some people will stop the medicine, and then a month later their symptoms come back, and they come back to me and say, okay, let's restart, ivermectin, let's try some, maybe add something else. And oftentimes nowadays, after speaking with Dr. Yo from Bruce Patterson's kind of collective of physicians, the Incel DX team, basically, I've started really kind of pushing people, let's try Maraviroc with ivermectin, because they've seen a lot of success with that. I haven't had a lot of experience with it myself yet, but they have. And based on their experience, I think that that's definitely worth a try in people who didn't get to, 100% on ivermectin alone, or they did and then it came back. Maybe just give it a boost with the Maraviroc. But yes, some people stay well, and some people stay well for a time, and then they get worse again, and you have to repeat it. And what's happening in those people? They're it just means that we didn't completely treat it, and that's, I think, one of the reasons why Incel DX exists, is to help those people realize that the pathology isn't gone yet. Even though your symptoms are gone, maybe we should continue longer until the inflammation that we're seeing on the test is completely gone.
Got it. Thank you very much. I'm going to look at a couple of, time. We are over an hour, and can we ask a few more questions, or should we do another session?
I'm okay. I mean, if you're okay, I can continue with you.
I'm totally okay. So this is what I've been doing for a whole year. So let's do this. There is a question, and for the cool beans, we try not to provide specific answers for specific patients. We can talk in terms of hypothetical, because it's not an advice for anyone. A question here: can my mother, 98 pound, take ivermectin for systemic protection? She has a pacemaker, Eliquis 2.5 milligram blood thinner, metoprolol ER succinate 50 milligram for AFib, furosemide 20 milligram for congestive heart failure.
All right, so I get a lot of questions like this. And I mean, obviously I can say in general for somebody, if a patient of mine had similar issues, what would I usually recommend? So I think some people have a misconception, because ivermectin and warfarin interact. They think that ivermectin is a blood thinner. It's not a blood thinner. It really doesn't say much about ivermectin. More it says about warfarin, which is famous for interacting with almost everything. So the fact that ivermectin interacts with warfarin is not surprising. A lot of things do. And so it just increases blood levels of warfarin and increases the blood thinning effect of warfarin. But it is not a blood thinner itself. And if anything, the fluvoxamine is a bit of a blood thinner. It has some of these antiplatelet effects. But ivermectin doesn't interact with Eliquis. It doesn't interact with anything that I saw in that patient history. Whether or not somebody should use it is a different story. Like coming back to this side effect of dizziness. If you're 90 years old and you've fallen down before and multiple falls, ivermectin, if it causes dizziness, we don't want you to break a hip. That's worse for you than probably COVID. That's often the triggering factor that kills people in their late ages, is falling down, breaking a hip, and getting hospitalized and catching pneumonia, and maybe COVID in the hospital. So you want to do everything possible not to have somebody elderly fall. And if there's dizziness on ivermectin, that would probably be the greatest contraindication in the elderly.
Got it. Thank you very much. Liza says, long hauler brain fog feels like dementia, even with ivermectin and steroids. Any ideas what will help?
So in general, my approach to long haul syndrome is this: if you don't have the Incel test results, Incel DX test results, we take a stepwise approach. We try different things. If you have found something you found online that, hey, this thing might work for me, I'm open to it. So in general, in my practice, I start with ivermectin. If they can add Maraviroc, we try Maraviroc. It depends on if you have a resolution or not. You try one thing for a couple of weeks. If you've gotten some benefit, you might keep it, like ivermectin, for example. If you didn't get any benefit, you might stop it and try something else. So you might go to Maraviroc ivermectin, or you might go to adding fluvoxamine. If fluvoxamine doesn't work, or it hurts, it harms you, you might try Elavil or amitriptyline. That's had some some results in some people. You might try colchicine, maybe colchicine works for you. I actually, I'm glad that I remembered this. One patient, back in the beginning of long haul, I was telling him, colchicine, aspirin, this and that. And he was like, not working is, it doesn't, I feel worse. And he just happened to take naproxen for some aches and pains for like 3 doses. Like he took it for, a day and a half basically. And he came back and told me, all my symptoms are gone. I was like, amazing, wonderful. Thanks for sharing. So now I tell people, a lot of times I'll tell people, hey, by the way, this one guy just took naproxen. That's what did it for him. He has no symptoms anymore after 3 doses. And just incredible. So you just have to keep trying things. You have to be patient. I think it's possible to heal from this. Eventually most people our bodies will probably get rid of whatever viral remnants there are. And hopefully, some people come to me, they said, when I was a teenager, a recent patient said, I had post-viral fatigue for like 2 years. It was horrible after, I think it was EBV, and then I got over it. And so after that experience, she's now experiencing long haul. And she says, I'm not, I believe that this can go away because I've had something like this happen before and it went away and I got over it. So I think people just have to have hope that you can be cured. And I think this is kind of like one of my pet peeves is when people go to a doctor and they tell them that you're incurable, that you're a hopeless case, you can't be, fixed, just forget about it, and I mean, I understand where they're coming from. They don't want to give people false hope, right? But, just the brain and just, even the placebo effect is so powerful. If you can give people hope and really convince them, sometimes it's not even about the drug. Where does real healing come from? It doesn't come from molecules, it comes from the creator of molecules, right? So healing comes from above. It's not always about finding the right thing, but, some kind of grace happens and you're healed. So people have to believe that any disease can be cured. So this is my personal belief that any disease, short of, your death illness, your deathbed illness, can be cured. Whether or not it's cured or not, not every patient can be cured. Certainly not everyone's willing to do everything they need to do. Not everyone will find that, circuitous path towards wellness, but there is one. The body can heal from anything. You just have to remove what's preventing the healing. So the body naturally heals. It's not like we're healing you. We're just removing the impediment. So with long haul, you're stopping the inflammation that's preventing, for example, like my understanding of it, at least one possibility is you're stopping the inflammation so that your macrophages that have the viral remnants can digest them and get rid of them. They can work properly. They can stop creating, the inflammation to begin with. So it's this vicious cycle. You interrupt it, your body heals on its own, and then you can stop the anti-inflammatories because you don't have a problem anymore.
Absolutely. Brilliantly said. Thank you very much for this. And once again, those healthcare professionals who feel that they may not be able to help and they just tell their patients that, hey, this is just you're depressed, or there are solutions. And so far what I've seen, Dr. Haider, is that patients it takes some time, some months, but they become 100% once again. I want to quickly just add something here, which I have been very passionate for some long time about the long hauler, and what I'm seeing is the following. So first is the viral hit and run. So let's say this is a macrophage, or this is a dendritic cell, or this may be some stem cells in the bone marrow that are making WBCs. And as the viral load appears, the infection appears, and they are in a hurry to proliferate and make copies, they open up various genes, and those genes are then imprinted. This is what we say in the innate arm side, trained immunity. And then the newer macrophages that are developing from the stem cells or that are present, they just are with those genes open.
Mm-hmm.
If this is the case, if let's say, so we do not know exactly what is the problem. If this is a problem, then steroids would help, because what steroids would do is that they would provide a break to the immune system. As you were just saying, allow the macrophages to kind of clean themselves up and heal. So they would provide a break to the immune system. Newer cells will be produced less. Older cells would have a chance to die off, and then the system would be reset. So this is one possibility. Then it is also a possibility, and Dr. Paul Marek, the credit goes to him, over a couple of days ago, we were talking about long haul, and he said that there is a study. He sent me the study. I would discuss it with the cool beans in a few days. He said that in some cases, in some patients, not the whole virus, but there is a remnant of virus without messenger RNA in it. Imagine the dead body of the virus, the zombie virus is running around, and it is just present. And it actually makes sense that imagine if this was a B cell, and that cell itself had the virus in it as well. And now the virus was not fully baked yet. RNA was not inserted in it yet. It was being built. And then B cells started proliferating to respond to the infection, and it would just keep making copies of the virus with it. And this presence of these spike proteins on the surface would continue to bother the immune system. If this is the case, then ivermectin would help a lot because ivermectin binds with the spike protein. So that means if steroid didn't work, then ivermectin would end up working.
Dr. Bean, I have to jump in here so I don't forget it. Can you just talk about, I'm starting to see a couple of people who have vaccine side effects. Could there be something like this going on with people who have these side effects?
Yes.
And could ivermectin possibly help them because of
Absolutely. Absolutely. So what is happening is, so let me add one more mechanism here and then answer your question as well. So the third possibility is that folks have gotten so let's say immune system, this was the B cell, it got triggered by the COVID and made antibodies. These antibodies went on and got lodged on mast cells as well. Correct? And in some people, they don't even need the antibodies to be lodged on the mast cell. Their mast cells are just generally very upset, and they are moody, and they would degranulate very easily. But now let's say we have primed the mast cell as well. So if this is the case, then these mast cells are going to start degranulating for every inflammatory cytokine produced. And then managing this will be through antihistamines. So that means your cocktail to test with is steroids, ivermectin, antihistamines, colchicines, fluvoxamine, and finally the question about the COVID and the vaccine. So look, at the end of the day, what happens is when the vaccine, so let's say this is a vaccine particle, lipid nanoparticle, has messenger RNA in it. The particle enters this cell. So here is a cell. It came in and gave off the messenger RNA. That messenger RNA is going to help produce spike proteins. And those spike proteins will be broken down by endosomes and finally presented here on the cell surface. Now, this is the same spike protein pieces that the actual virus is also going to present. And if the immune system does not like very well this thing and responds in some people negatively, just like sometimes people have allergies, then the vaccine is also helping produce a similar response in the immune system. The only grace here is that vaccine would not be continuing to produce spike proteins for a long period of time. So they would have these symptoms, but then eventually they will recover faster compared to a long hauler. But the symptom set could be the same as a long hauler. So I thought that I would at least jump in and kind of.
And what about ivermectin, Dr. Mubin? Do you think they would have some role to play in the vaccine side effects?
Absolutely.
Minimizing them.
Yes. So here is the reason. The reason is that so let me add a little more to this talk here. And fortunately, the cool beans have been having this talk for some time. So let's say this was a cell, some cell. Let's say it's a fibroblast, or let's say it's a dendritic cell, and it was presenting this. Let's use it fibroblast or a muscle cell, and it is presenting an antigen. Now we know that cytotoxic T cell is going to come in and dock here as well. Correct? So it is standing there with that antigen. And now naive T cell, so naive T cell becomes activated here. The T helper 2 becomes active or becomes T helper 2 or T helper 1, and the cytokines start and the antibodies start. But one part of that all is activation of the cytotoxic T cell. Cytotoxic T cell is going to do what? It's going to destroy the cell. That is their function. So as soon as they're activated, they're going to destroy the cell. And when this cell is destroyed, what would happen is the guts of the cell are going to spill out, correct? Which contain small pieces of spike protein as well, whole pieces. These tiny pieces are going to be picked up by macrophages here, and all of a sudden, immune system would start responding. So if ivermectin was present in the system, ivermectin is going to bind here. And it is going to prevent this immune system going mad That is one. And secondly, ivermectin is going to suppress the NFK beta pathway, and that would also help with the inflammation. So if people are getting COVID side effects more than those general side effects and they are now lingering, ivermectin actually would help a lot.
But it shouldn't interfere with the vaccine efficacy.
Not at all. So not at all. So here is the good part of this. And we have done this discussion. So let's say here is a cell, and the cell got the vaccine. And now let's make another cell here which got infected. So let's say this got the SARS-CoV-2. And let's put ivermectin with both of them. Ivermectin here, ivermectin here. First thing, the spike protein from the virus has to bind to the ACE2. And there is an in silico study, and I have references for all of those studies. Anybody who wants it can ask me, and most of my videos about ivermectin have the list of those studies below. So first is that ivermectin binds here. So it would prevent or stall the entry of the virus to the cell. Now, when a vaccine enters the cell, it does not enters through using ACE2. It is actually a lipid nanoparticle that just fuses with the cell membrane. So ivermectin would do nothing. It won't stop vaccine's action while it would disrupt the virus. Then once the virus is inside the cell, virus is going to make, the proteins with the ribosomes, and it is going to make RDRP. Plus, it's going to make 3-chymotrypsin-like protease. Both of those enzymes are necessary for viral replication, and ivermectin disrupts them both. Now, if you go back to the vaccine side, vaccine does not need to make 3-chymotrypsin-like protease, or it does not need to make RDRP. Vaccine is just going to give off the messenger RNA that is going to be fed into the ribosome, and ribosome is going to make spike proteins. There is nothing else needed. So once again, ivermectin would do nothing here. Then, once the virus is now being built, virus is sending its cargo in the cell. This is a Cali study, and the cell is prevented by the virus cargo to produce interferons, right? So now ivermectin prevents this because the viral cargo has to load onto importin alpha and beta, and then they go to the nucleus, and ivermectin disrupts that. So the cell can continue to produce interferon and stay strong. The next cell stays strong as well. Vaccine does not do that. Vaccine has no business trying to disrupt interferons. So ivermectin does not disrupt that function either. And finally, the final function is the nuclear factor kappa B. So nuclear factor kappa B is a function which vaccine or the virus can cause and the vaccine can cause. And that is when the vaccine is taken, there is the inflammatory pathway, and that would cause in nuclear factor kappa B to be activated, which would cause cytokines. And ivermectin blocks this or stalls this. This is the anti-inflammatory behavior. This behavior is actually possible in the presence of vaccine, because nuclear factor kappa B is just a function. That means in the presence of vaccine, when the ivermectin is given, vaccine's function can continue training the immune system, but inflammatory responses can be modulated downwards.
Which is great. Yeah, thank you. Thanks so much. Yeah.
You're very welcome. So I wanted to put together that menu of the things. So continuing here, we have you, and we're not going to let you go until we.
It's my pleasure. I'm enjoying it. This is probably the most fun I've had in the last 4 months.
Thank you. And by the way, so Dr. Syed Haider, Dr. Syed Drbeen, so we are Syeds as well.
Yeah, so some people came to me thinking that I was you, actually.
You are me. So I mentioned that Dr. Syed Haider advises against using caffeine with fluvoxamine on his website.
So I don't remember writing this on my website or mentioning this. I mean, the only thing this reminds me of is, right. I think what they're talking about is long haul COVID. You might consider avoiding caffeine, maybe. I might have written something like that, avoiding something like a stimulant in long haul, possibly. But what this reminds me of is Dr. Patterson's group. When I talked to Dr. Yo, who works with him, one of the patients came back to me and said that they gave me a list of foods and juices and things to avoid, avoid these fruits and things. when you're taking treatment. And, I looked it up. It wasn't something that I was aware of, but, a lot of juices like grapefruit juice famously inhibit some of the enzymes that, metabolize Maraviroc, especially. Doesn't have as much of an effect, I think, on ivermectin, but Maraviroc, you could actually increase the levels probably by having juices. So yeah, but caffeine, maybe for long haul patients, if you're sensitive to, right, sorry. Caffeine and fluvoxamine, of course, yeah. So this is also a famous interaction, right? Caffeine will stay in your system. It won't be metabolized out when you're on fluvoxamine. So that's definitely very, very important. I have to stress that with everyone. And when I send people, my directions message, when I'm prescribing fluvoxamine, it's like, star, no caffeine at the top, at the bottom, no caffeine. Yeah, so definitely. Sorry, I had like a little brain fog there for a second, but definitely no. It's not about no caffeine. It's more about, the caffeine's not going to go anywhere. So if you drink a cup of coffee every day, by day 10 on fluvoxamine, you're going to have like something like 9 cups of coffee in your body, right?
Oh, wow.
It's not exactly. I'm just exaggerating, but you're going to have a lot. It's going to stay. It's going to accumulate. It's not going to leave as quickly. So you can experiment with it, and it's just more going to be uncomfortable. Like if when I was in college, I used to one night I tried caffeine pills to stay up and study, and I was so buzzed that I couldn't even think straight. I mean, most people aren't going to end up in the hospital with a caffeine overdose, but in the elderly, certainly that's something to worry about with palpitations and triggering an arrhythmia or something is possible. But you just have to be careful, basically, with caffeine. So maybe if you're addicted to it, I mean, I tell people just try decaf. So I had a coffee shop owner come to me with long haul, and she had to try fluvoxamine, and she's like, I work in a coffee shop all day. I won't lie to you. I drink coffee all day. And so decaf has some caffeine, but it's tiny amount. So it's not like a absolute contraindication. It's more about you have to be careful.
Got it. Thank you very much for that. So I'm going to continue here. Some more questions, but more of the questions here were in terms of what not to take. Here, where should we get these treatments if we live in the UK? So this is a very common question that has been asked. That fine, for US, we have folks like you. Thank you very much for helping us. But what do we do for UK and other places?
So, I think for the UK, you have to just contact all the doctors who are prescribing ivermectin, one by one, and try to find somebody who's willing to prescribe it for you. Or, if you're dying, a white lie, for example, it depends. I'm not completely opposed to, if somebody comes knocking on my door, looking for, it's a bad example, but basically, in some cases you might need to make something up, so some patients, for example, will find a doctor who's willing to prescribe it to them. And some patients will just say, hey, I live in Jacksonville, Florida, and they tell you that. I'm not checking. I'm not looking up your, internet address, IP address. You tell me you're in Jacksonville, Florida, that's where you are. I'll send you a prescription to Jacksonville, Florida. So, if somebody has a family member in America who can ship them something from CVS using GoodRx, and they can find a doctor who's willing to prescribe it to them. And the same thing with people who are in states that I'm not in. I tell, like, somebody calls me from California, I'm not licensed there yet. Hey, drive to Nevada, okay? Call me on the phone. Establish your care with me. I can send you a prescription in Nevada. You can transfer it to California when you drive back. Hint, hint. People have to get creative, and when your life is on the line, I don't think a white lie is going to be held against you, but you have to figure it out yourself, basically.
Got it. And one more addition to this, many of the cool beans have been reporting from UK that they have been going on some websites that allow the ivermectin to come in from India. So that is one. And secondly, for my pleasure, I was happy with this one, that Dr. Tina Pierce, who is now managing long COVID in UK, she has started administering ivermectin as well, in addition to antihistamines. So it may be that reaching out to Dr. Pierce would be useful. And then hopefully her influence is going to start increasing, and more doctors that know her are going to start giving the ivermectin as well. So it may be useful to actually connect with Dr. Pierce. So thank you very much, Dr. Haider. I'm going to continue to the next one. So the Redditor folks, I thought we would not be able to go over all of them, but thankfully Dr. Haider has given us time. So can you, and one more clarification, sorry. Dr. Bruce Patterson, somebody was asking what is Incel DX. So Dr. Bruce Patterson has been on my shows as well. Please just search for his name or just Google it, Dr. Bruce Patterson. He has a company called Incel DX. They have created a set of labs to figure out what may be happening with long COVID. And Dr. Yo, that Dr. Haider was talking about, it is funny, Dr. Haider, it's a small world. Dr. Yo is the class fellow of our medical director, Dr. Ahmad Zafran.
Oh,
We
wow.
studied together. So I've had Dr. Yo on my
Yeah, I've seen that.
my show here as well. So he has been working with Dr. Bruce Patterson, and they are working on figuring out labs and the management for long haul. So you can just Google them and you can tweet at them as well. So here, can you clarify what foods, drinks to avoid while on ivermectin for long COVID? So coffee, fruit juices, nuts, coffees, dairy.
Yeah, so I think, I don't have a lot of insight into this. I mean, I don't tell people to avoid anything other than maybe junk food or something that triggers their symptoms, So some of these things might be, people thinking about like inflammatory, like fruit juice, for example. I think I mentioned to somebody, maybe try avoiding fruit juice. Because it's just a lot of sugar, maybe eat the whole fruit instead. So what we're talking about is maybe having an anti-inflammatory diet, because inflammation is the problem for most people with long COVID. We're trying to give you the best chance of recovering. But, honestly, the food is probably a little lower down the list. When you're using medication like ivermectin, as long as you're not, a lot of people come to me with long haul and they have gotten to the point where they just know they can't eat certain things because it'll give them terrible symptoms. So some foods, for example, dairy, have a lot of histamine in them. And if histamine is part of your pathology, it's not going to really help to be having, food that already, strawberries or dairy, something that's high in histamine. So some of these things are particular to the patient. One of my long haulers, he had some chronic inflammatory issue, and he said that the only thing that worked for him was actually juicing fruit. And so I tried, I told him, like, what about, green juice, or, maybe try something else. And, he said it doesn't really work as well. So he avoided the juice, in the beginning of the protocol. And then later on, we decided to try it, so everyone is different. People should be a little bit flexible, and with food, I usually, just outside of this particular, scenario, also, I tell people that everything is really particular to you. You can't say that everyone in the world, coffee's bad for them or coffee's good for them. I mean, you can find studies that say anything is good for you. Yes. It seems nowadays. It's just people are very, very different, and they have to be willing to examine their own reactions to foods and figure out what works for them and what doesn't, and hopefully avoid things that don't work for you for whatever reason.
Got it. Thank you very much. So stereo match, I'm going to skip over the food related questions and go down here to, there was a question from an India Redditor. So Krishna Zim from New Delhi had a question. She got dengue in 2012, and since then she has had pain, tingling in her extremities and body, but always on one side. Next day it is on the alternate side, never on the same side. Then in December 2020, she got COVID-19 and her family too. She was given ivermectin, doxy, and during that disease, her symptoms went away. Later, they returned back to their daily cycle. She occasionally gets a relief if she is distracted or goes out. 35-year-old female, 5 tall, 45, no diabetes. So I'm going to understand the question here. The cyclical nature of it suggested to me a couple pendulum where the activation shift from one to the other seemed to me perhaps be some kind of migraine maybe. So is it possible that of course the patient is saying that they are experiencing it. Is there some mechanism that shifts the symptoms from one side to the other, and any solution for this?
Yeah, I mean, this is a fascinating scenario, and I've never actually heard of anything like this. So I would return the question back to you, Dr. Mubin. What do you think about it? I'm drawing a blank.
So I have not heard of this cyclical change on daily basis, from one side to the other. Almost seems like one side of the tissues getting inflamed than the other, but there is no such barriers in the brain. So I am at a loss as well to figure out what this may be. So why not we table this question for the time being? Stereo Match will talk a little more and figure out what to talk about. So here's the good news. We have almost gone over all the questions on Reddit. So Dr. Haider, you get a trophy for that.
Wonderful. Yeah.
So I'm going to now just have few last questions from the live. And then so here is Kevin Brazda, Dr. Bean. Let's host discussion with Dr. Teslari, Paul Merrick, Syed Haider, Pierre Corey, topic human rights and absolutely.
Yeah, this is a big issue. I mean, what do we do? I think we need to honestly get lawyers involved, maybe, have some pro bono lawyers involved in this. Because if you have enough money, you can go to the judge and get a court order. You hear about this in the media here and there. If you have enough money, you can fly out to a different hospital that Dr. Corey's working at that week,
Right.
But if you don't, you're at a loss. You just have to push for it yourself. And
absolutely,
I mean, it's really, really.
So lately, I have been actually thinking about it that we should have a number of lawyers now starting to sue FDA, CDC, WHO. Number one, and number two, Dr. Teslari had said that we need a new WHO. I actually think that we should try to figure out how to start a new. Just like nowadays, there are open music, open movie, open softwares. I think there should be an open health system as well. And we should figure out, can we create our own WHO, which then becomes so authentic and so influential at some point that it can actually be a parallel entity? I think we'll need lots of resources for that, but I think that time is now to do that. So one more question. Cheryl says, does ivermectin work with malaria? My friend, 71-year-old female, got malaria as a child and went untreated. She still feels bad with malaria type feelings after all these decades.
So I'm not aware of any benefit in malaria. I haven't treated anyone with malaria. But I think that ivermectin its profile has been raised. And so people are starting to come who have other inflammatory conditions and they just want to try it. So, I've gotten mostly patients with Lyme disease, but other people who have just non-specific inflammatory complaints, aches and pains and arthritis type of things, sometimes will take ivermectin and get better. So if that's the case, if you can be on ivermectin every week, and your aches and pains go away, that's fantastic. It just means that we're addressing the root cause in some way, right?
Correct. So I think there is one more question. So one more question, and then we. So Gaurav Shah says, post COVID-19, I developed idiopathic urticaria. It's 9 months now. Still have to take Allegra at 120 milligram daily.
Yeah. So this sounds like long haul, some version of long haul. It's not the most common symptom that I get. I haven't actually seen that before, but it's I'm glad that you can manage it, and I hope there's not any side effects.
Yeah.
But it's certainly worth trying one of the other treatments to see if you can actually address the root cause, stop the inflammation completely, and get off of medication. So it's just the general approach to long haul symptoms of any kind.
Yeah, it seems like the mast cells are active at this time. So there may be something that is bothering the mast cells. So Dr. Haider, this is it. We are at the end of it. Thank you so much for your presence.
It's been my pleasure. Absolutely. Yeah, I'm so glad I could spend time with you and learn something from you and from the cool beans.
And actually, the first part of this video where you have given your protocol, I think that is the gold for anyone in the world. So thank you for doing that. Thank you for helping.
Absolutely. Thanks so much for having me.
Thank you very much. So Cool Beans, thank you very much. So this was a special show today. Please like, subscribe, and share. And I would see you tomorrow morning. Bye-bye for now.